Dr. Chris Kent asked me to come do a presentation based upon information you're about to see. So I'm using you guys as the trial run. So you get to see where Epic's research platform is coming from, and then we'll get your opinion on it towards the end. But here's basically what we've done, is there are doctors of chiropractic from 12 different clinics, Epic clinics, have collected and recorded information on a cumulative 2,300 plus cases. The information is recorded in a software program utilized by the Epic technique called Sonus Blueprints. The designer of this program is in the back, Dr. James Beadle, one of our board members. Once you take a look at what this program is capable of recording and interpreting and pushing out data for us, it'll blow your mind. And I'm just going to try to give you some insight on it in this presentation. The data points of the collected information were cross-referenced for review and consideration. So here's the point. You can pull all kinds of data, but then you've got to be able to look at it and say, well, what does that matter? How does this piece of information compare to that piece for my benefit, for my patient's benefit, for moving chiropractic forward, for comparing techniques? One thing Dr. Bueller just mentioned, he said, hey, maybe at some point we're going to be able to look at a case and know what approach might work most effective for that. This is Epic's way of putting ourselves on the map and saying, here's what we represent. Here's the facts, the data, the statistics. This is what we're trying to encourage our profession with. But not just from a techniques perspective. Inside Epic, we have a very high accountability. I mentioned that to you before. We need to push accountability inside our profession more. We can't just have a lackadaisical hands-off approach. Being accountable means you have to be able to look at certain parameters before the adjustment, certain parameters after the adjustment, and see what it is you're causing. We are causing change. Is it a good change, bad change, indifferent? Well, let's see what the data shows us. Because once again, in our hearts and minds, we are all the best. And all chiropractic works. But being specific matters. You got your little... this is one of them. Yeah. You guys all got your D.D. Palmer, Chiropractic is a Science, just so far as it is specific. So we are doing everything we can, trying to be as specific as possible. The way this information is recorded. Person's name is entered, demographics, exam findings, general x-ray findings, specific biomechanical findings on the pre-x-rays, including genetic anomalies. We record lots and lots of genetic anomalies. Whether the atlas mass is taller on one side than the other. And if it is taller in its mass on one side, is it because the superior mass developed abnormally tall to match a condyle that was high? Or was it because the inferior mass developed low to match a C2 body that developed low, higher on the other side? Where did innate make its accommodations? Did the posterior arch insert at a weird angle? Is the posterior arch just fatter on one side? Is the transverse foramen centered in the lateral masses? Is the TPs, how are they? Is the mass of the atlas on the horizontal perspective bigger? We look at tons of genetic data points. We're up to 25 different genetic anomalies that we study for in Epic. If when I say that you go, 25? Ooh, I don't even know if I can think of 5 of them. That means you need to get to some training with Epic. And most of you in here are training in this procedure in some way or another. You can't train enough. I don't know how else to say that to you. It's just we're always training and learning, and there's always breakthroughs. And you can hear the same information. I know this happened with Bracken before. You can hear the information from us one time. You come back and you hear it again, and it goes in on a deeper level. You're at a different place in life. Maybe you weren't in clinic, and now you are. And for field practitioners, it's the same way. You're in a certain mindset the first time you hear some information. You compare it with your own reality, and the next time you hear the same information, it just goes in deeper, and it makes you think and challenge more, and it just helps you become a better doc. So when we're entering the data, we've all been trained to look for certain things and enter the components. But you look on here, and it's your upper angle, your lower angle, your rotation, your C2 rotation, your atlas plane line with C over A. You have all these different reference points, including all these different genetic factors. And then, of course, you take post x-rays immediately after the first adjustment. That is Epic's standard protocol. You must post x-ray immediately after the first adjustment. And you enter in your post x-ray information. The topics I'm going to be reviewing in this talk, and mind you, when I do this at IRAPS, I won't quite talk about EPIC very much, because you have to do it as just a general research platform, and I am a little terrified to go do this talk, by the way. I haven't mentioned that to you yet. I've never even been to IRAPS. And the researchers, they intimidate the heck out of me. I've never written a single research paper. So I have to go in there and say, hey, clinically, let me show you what we're tracking. And then you research geniuses can scrutinize it and help us learn how to interpret it even further and how to clean up the correlative data to be able to say for certain this data equals this outcome or assessment. So I'm just showing them, here's what we have. But inside that data, we're going to have four main points that we look at. First, we're going to review general demographics and radiographic findings. And the mindset behind this is we're not interested in just pushing EPIC forward. We are interested in raising chiropractic. So a lot of the data that you're going to see in the correlations is just good data for chiropractic. You're going to see at the very tail end of it, after we look at demographics and radiographic findings, then we'll look at orthogonal radiographic findings compared to the physical exam findings. Then we'll look at osseous asymmetries and their effect on the orthogonal analysis. And then we'll take a small little look at EPIC and how we're using this data to quality control our doctors and create a standard of care that we're all held accountable to. So the majority of the data I'm about to show you is for chiropractic. Period. The end of it is a glimpse as to how we quality control our procedure. And that is actually the one point that Dr. Chris Kent, if you don't know who he is, he's just a phenomenal researcher, chiropractor, just a good person. And he's somebody who, when he looked at this data with me, that's what excited him the most. That's actually why he put us at IRAPS. He said, I want you to show them what you're doing as a technique to measure a standard of care by which you're trying to hold your technique practitioners accountable to. And he said, that is what the profession needs to see the most. But what will interest them the most is going to be the other findings first. Because once you start talking about a technique, well, now they go, oh, that's not my technique. But the reason why I want to show that about our technique is to hopefully inspire the other techniques to do the same. That's one of the biggest challenges when you're head of a technique is you've got to inspire quality and excellence and make sure people know. Like, it's very interesting when you listen to Dr. Ian Bulow do his presentation. And you saw the big Blair slant on because he's a Blair practitioner. It's his world. It's his reality. And I love seeing that. That's fun for me to see his excitement and passion for it. Some people might go, oh, that's a Blair talk. No, it wasn't. That was an upper cervical talk. But he has his Blair flair, right? So we have an EPIC flair that's hidden, that's inside the details of the statistical monitoring that we have. If you want, by the way, some of you have said, when are we going to hear about EPIC? This is EPIC's annual symposium. Sunday, we're going to have two major sections on all the upgrades and advancements that have happened in EPIC, the technique, over the last year. And you'll get to see those, okay? So don't feel like you're being gypped out on EPIC stuff. It's there. All right, so let's just look at some of the findings. So remember, we have several thousand cases, 12 different clinics, all contributing data. So let's just ease into some of the fun. When you're looking at this, total age versus personal age, what that's referring to is anytime you see total versus personal, inside Sonus Blueprint, when I enter my data on my patient base and on my exam findings and x-rays, that's my data. It's being compared to the data from 12 clinics. The data from all 12 clinics is EPIC's standard of care. Is that standard good, bad? Well, you have to look at the data. But you have to compare yourself to something. In fact, that's one of the funny phrases we use in EPIC all the time. Compared to what? Oh, my adjustments worked great. Compared to what? I'm doing better now. Well, what? Compared to what? Well, compared to how I was last year. Oh, good, you're making progress. Oh, my technique works better than yours. Oh, you're comparing it to mine based on what parameters? We're right, you're wrong. Okay, compared to what truth? So we have to compare ourselves to something. So what you're going to see, a lot of this is going to show my personal data from my practice compared to 11 other doctors. So when you see total, that's the clinic group perspective versus my individual practice. So just looking here, this is just age demographics of people that come in. So see how I have a bunch of these higher marks in these ages? That's because I practice in Florida.
Welcome to Clearwater.
I have an older demographic. And this is Heaven's waiting place. I get it. So they love gentle adjustments here. They're all afraid their bones are going to break with any single touch. So, I have a higher age demographic. Take care of an older population. Let's talk about cervical curves. So I start off with one just kind of fun one, but we're immediately going to go deep on some really cool data. What percent of the time does this age group have reduced curves, straight curves, reversed curves? On average, 0 to 10-year-olds have a neck that's 24% normal curve, 43% reduced, 29% straight, 4% reversed. Let's skip to the 61 to 90-year-olds. The people we think should just have the worst spines because they're older. 11% of them have normal curved necks, 46% are reduced, 37% straight, 6% reversed. But 11 to 60-year-olds, only 7% of them have normal curved necks. 23% it's just reduced some. You've lost some of your curve. 62% of them are already straightened out. 8% are reversed. So the demographic of 11 to 60-year-olds have the highest prevalence of straightening and reversing curves. This is weird, because I thought people lose their curves because they're getting older. Now, a completely different piece of data that probably has nothing to do with that is, let's see, computers began coming out in the mid-1990s. Oh, cell phones, that's a completely separate piece of data. It has nothing to do with the loss of curves in the necks and stuff. Yeah, Pokemon Go. Amazing. Still. Pokemon. So, all these people walking around like this, all of them on the computers like this. How much is that whole text neck? Is that a reality? Our data is showing it's a huge reality. So what about if we now add in disc degeneration compared to curves? We start to see some interesting correlative data. The trends of disc degeneration, degenerative disc disease, C4, C5 disc begins manifesting demonstrable degeneration, significant degeneration, around the age of 41 to 50 years old. So let's just look at it right up here. So here's degenerative C4, 5, and just look at your marks. It starts coming down 2%, 4%, and then it jumps to 10. This is a double. Then it jumps again. It doubles at the age 41 to 50. So that's quite interesting, because when are we starting to see people decline? Well, statistically, their C4, 5 disc is trying to sustain itself pretty well. But whatever's going wrong, by age 41 to 50, it starts to lose its integrity. Now, C5, C6 disc begins demonstrating the degeneration around age 41 to 50 also, whereby it's doubling its deterioration prevalence for the next 2 decades. So we looked at C4, 5, which is right here, and it started doubling. Look over here at C5, C6. It's also doubling. But then look at the difference. C4, 5, at that point, stabilized. In the next 2 age groups, it still held the same percentage of prevalence. But not C5, C6. It started deteriorating, and then it just kept deteriorating. It's pretty interesting data. C6, C7 disc appears to only show deterioration after the age of 50. So it also deteriorated over here, but not as aggressive. And then it just kind of deteriorated some and then just hung in there. So the big culprit of degeneration, obviously C5, C6, but it's just interesting to watch when is the age group that really the body just kind of gave way. It's a 10 to 15 year to 20 year period of time where enough's enough. Now, people could try to correlate that with other findings of, well, maybe you're losing the elastic capability, maybe your telomeres. People can talk about maybe why the body couldn't adapt quite so well. around that age. But that's where the body started to drop its disc integrity. Now let's compare anterior head carriage and how that affects disc destabilization. You guys following me still?
Yep.
Interesting, isn't it? Anterior head carriage. The overall trend of disc degeneration seems to increase as the anterior head carriage increases in all cervical discs except for C7T1. So the C5, C6 disc was the most commonly degenerated disc in all cases involving anterior head carriage, and it appears to have a significant increase in prevalence to degeneration after the anterior head carriage is over 30 millimeters. So just look at the data up here. With anterior head carriage, you can see on the left what levels we're looking at. This is not an age factor. This is just a matter of how far people's heads are. So when people's heads are over 30 millimeters anterior translated, right here, then you're looking at 20%, 21%, 22% is the commonality of how the C5, C6 disc goes back. And you'll see a little increase in the others, but not much. The biggest disc that gets affected most with anterior head carriage seems to be the C5, C6 disc. And the more anterior head carriage you have, the more likely it is that C5, C6 is going to go back. And we could all theorize as to why. You know, the posterior facets are supposed to be handling the weight with a good curve, and so that shock absorber mechanism is supposed to be on the back side. But people's anterior head is now moving that weight onto the front side, so the disc is now handling more weight than it's supposed to. Maybe that's why it's going back. Yes, sir.
Do you think that level is more prone to whiplash?
Could be also.
Because
So we probably
pivots the head so big, and
So we probably should look at the effects of anterolisthesis and posterolisthesis also showing up on the x-rays, because that would indicate whiplash occurred. We'll do that in a minute. You guys probably already know this, but for every 1 inch of anterior head carriage, you're adding 10 pounds of pressure to the discs, to the lower neck. That was in Physiology of Joints. So Dr. Deutschman, thanks for the transition.
well,
So how does, when people get in accidents and have whiplashes, is it more prone to cause further disc damage? And which mechanism of the hit, which mechanism of the translation, how does that affect the decline of the disc integrity? Posterolisthesis cases, so that's where the vertebrae is slid backward compared to, so if you're looking at me, because he's not, you started chiropractic school yet?
April.
In April, okay. So it's where the vertebrae, and there's a line on the backside that Dr. Bulow mentioned in his talk about called George's line. That's if the vertebrae have slid backward or forward, not in a irregular motion, but actually just they're sitting there. It's a listhesis. You can put a listhesis under motion too, which is a fresh injury, but sometimes the old injuries are just showing you a shift in the vertebrae. That's called a posterolisthesis or an anterolisthesis. So a posterolisthesis case demonstrated a significant increase at C3, 4, 4, 5, and 5, 6, more so than anterior. So basically what this is, in cases where there was a posterolisthesis, this is the percentage of time those discs were bad, and which discs were bad. So 75% of cases with posterolisthesis injury have degeneration at the C5, C6 level. Versus an anterolisthesis injury at the same disc was only showing degeneration of that disc 58% of the time. So posterolisthesis injuries where there's actually been the vertebrae shifting back seem to show that it's going to have a more negative effect on disc integrity than an anterolisthesis weakness. Well, most of us are probably just going, oh, interesting. Oh, interesting. But it starts to add a different seriousness to why you need to be certain you're keeping people in good alignment as quickly as you can after an accident or during their football career.
Hold on a second. I get what Mike said out in the hallway of what he wished he would have said to everybody. Sorry. Mike, when we got out into the hallway, he goes, oh, and I meant to tell everybody. He said, I'm talking about my son, and my son's up in Michigan playing football. He goes, and we don't have, I kind of get chills, I get a little emotional. He goes, we don't have anybody up there to take care of him. they don't, or wherever he is, there's nobody in his area, right? And so most of us in our own practice get calls every week, or at least we do, I guess, because of who we are, but we get calls all the time. Do you have anybody in? Do you know anybody in this state? And so anyways, just wanted to say, he said, I wish there were more people doing what all you guys do. And the word really needs to get out. And so he said he wished he would remember to say that and wanted us to share that. So.
Thank you, Sharon.
Well, that's awesome. It inspires us to recruit more people into chiropractic. Dr. Brooks, you recruited how many of your patients into chiropractic school?
54.
Wow. Wow.
That's a big softball. And that's what's awesome. I get throw him a softball, he's just going to nail that out of the park every time. Like, oh, that's like multiple home runs with one statement. Yes, ma'am.
It's like coming to these kind of meetings and getting to know each other and what type of quality of work we do, no matter what the technique.
Yep.
I would rather send someone to Ian Bulow than to someone doing my technique poorly. You know, so when we see the ones that are upping their game and making sure they stay with the program, going back to their basics, making sure they don't fail to do the post x-rays in our technique, I would rather send them to someone doing the right work in a different technique.
Agreed, and now you're going to have the objective person in me say, okay, well now what I would, if this, let me tell you a side note, don't make me do my rapid trails.
Sorry.
UCHC, Upper Circle Health Centers, I was stockholder of them, I fully believe in them. When I first met the owners of that, and they were talking about what they were going to do was putting Upper Circle franchises all over the place and getting a brand recognition towards this, and I was like, this sounds awesome. And I said, what are you doing to control the quality of care in the practices? And they go, what do you mean? I go, your brand is only as valuable as the quality of care being rendered inside that clinic, so what are you doing to ensure the quality of care of each of your doctors is top? And he goes, well, I mean, we expect you guys to quality control that when you're teaching them. And I go, that's a big assumption, brother. I go, you only going to bring on certified doctors? Or are you going to bring on anybody who's willing to do your franchise? So that was a vulnerability that you basically just talked about. So for me, when we get to the part of showing you what we do in Epic to try to quality control, it's because there has to be something reliable. There's got to be a standard of care that people can be held accountable to, and each technique has to create that in their own way. Yes, sir.
What was his answer?
Let's not talk about it.
Later tonight.
That's right.
That's the answer. You answered it.
And I love those guys. Ray Drury and Thad Vanyu, I love them. I think they're amazing people, and I think they've got a big passion for upper cervical. There's people on the business side, the promotional side, there's people that are on the clinical side, there's people on the research side. So we're clinical first and foremost and quality of care first and foremost. And so that puts us in a different reference, which is why we all need to be in the same sandbox playing with one another. So we can have that rub off on one another. Okay, I'm going to be doing a big talk this afternoon on this subject matter, so I'm just going to not talk to you about the importance of this, only of the prevalence of this. Prevalence is just how frequently is this occurring. There's something called styloid processes that most of you know about, coming off on the bottom of the skull. And here is just the prevalence of how often are the styloid processes on the bottom of the skull elongated. A little hint I'll tell you ahead of time, it can affect vasculature. So at different age groups, this is, Dr. Bulow, this is one of the things I wanted to tell you, but I wouldn't tell you until now, is when we look at the prevalence of these styloids being longer, on average, 48% of cases have styloid processes that have grown, calcified, genetically developed, that have become longer than the C1 transverse process. In almost 50% of cases, we found elongated styloids. The reduced prevalence of the styloid process in the age of 0 to 10. See how it goes up. And by the way, there's two different years here. In fact, I'll stop reading. I'll just explain it to you. In 2017, what's happening is I was starting to notice all these elongated styloids. Actually, I didn't know they were elongated styloids. I kept looking at x-rays and I kept seeing these prongs, these lines. I'm like, what are those? And I would see them more and more often. This was like in the last 3 or 4 years. And in 2017, I really started honing in on how often am I seeing this? Because I'm seeing this like a lot. What is that freaking line? I figured out what the line was, started cross-referencing with anatomy text, and I was like, are these supposed to be there? And if they are supposed to be there, 2016, yeah. And that's right. I was like, are these supposed to be there? Is this a genetic thing? Is this acquired? Is it from pathophysiology? What is this? And so in 2017, I started looking at them. By 2018, I was looking at them with a whole different depth. So I asked Dr. Beadle to help me pull up the difference in how even I was looking at them. And the frequency of what I was seeing was going up overall. The average actually went up between me thinking it was 1 out of every 3 people to going over 50%. And I was like, what does that indicate? That indicates I started looking deeper. That's why I started talking about with Dr. Beadle. I'm like, are you looking for these? He's like, yeah, I don't see them too often. I'm like, look deeper. And when you start looking deeper, like, whoa, I didn't see them. Because that's what this is all about, is seeing things we didn't see before. Albert Einstein has this phrase, discovery is about seeing what others have seen before and thinking something new. So we need to be looking at information and just poking another hole in the truth box. Or just making our hole a little bit bigger, stretching our comfort zone. But look at this, because in this group, it starts off as, on average, 20% of 0 to 10-year-olds have elongated styloids. But then it goes up to 40%, and then it stays at kind of that level. This is a very interesting piece of information because there is a discussion, when I go into this afternoon with you about elongated styloids, there's a discussion about whether these are acquired as part of some inflammatory response or injury or just a hypercalcification in the area, or a thyroid issue causing too much calcium to deposit, or bone spurs on the front of the neck supporting a disc weakness. Now maybe that calcification is leaking into the stylohyoid area. This shows it's most likely part of that person's normal ossification. Because they're maturing, they're ossifying in this area here. They haven't fully ossified here. So it's looking like that might be an actual genetic thing that people just develop elongated styloids, not because of an injury or a disease, but just most people have them longer than the Atlas TP. And there's a group called Atlas Prophylax. In their very first website that they put out, and they're physical therapists claiming to do what we do, by the way, in case you didn't know that. But in their very first website that they put out, somebody tipped me off about this, and I looked it up, and it had some weird stuff on there, like they were claiming that alien species came to the Earth and modified the human genetic programming to cause an atlas to be misaligned from birth to affect our quality of life and years of existence. Wow. And that with one Atlas Prophylax correction, you could break the genetic sequencing, you never need it again, and you're good for the rest of your life. So first, okay, that's pretty odd. But the second thing was, then they showed the styloid processes creating a joint with the Atlas transverse processes, and claiming that was the uniqueness, which is not the case, hardly ever. That's a really weird malformation. But the styloids are longer because of developing them according to this chart.
What about the correlation between the 0 and 10-year-olds and abnormal curves, cervical curves? Meaning they have more normal curves, but they have less normal curves. And as they get older, the extra strain on the anterior head carriage is causing that bone to develop longer. You know what I mean? From an abnormal load.
Maybe. But then we would see in the older population that still had a better curve situation, then we saw that those people had less likelihood of disc weaknesses and yet have the same likelihood of elongated styloids.
It's the aliens.
So another thing that we're tracking is, and this is a newer one, is we're starting to track the location of transverse processes. Compared to the mastoid and jaw and EAM, you can start to see where they are. It's in a graph tracking system that we do on X-ray. You plot points, the computer itself will make a reference grid per person, and it will track the location per person, and then put that in the overall data mining. Why would we do this? Is because, like Dr. Beadle mentioned, how are we going to figure out when do you use which approach? How often? Which quantum physics was required to adjust through the mastoid? That was awesome. That was awesome. Well, what percentage of the time is the transverse process behind the mastoid, or inferior to it, or up tucked near the jaw, or platybasia and basilar invagination where the skull softened and everything went up inside and the TP so high that maybe it's hard to contact? I remember I had one of my favorite comments that you made, Dr. Brooks, was I said, well, how would you handle that if there was an anatomical obstacle? And if I remember right, he said, I believe my body is also generating a frequency wave that I can send my energy through that to the atlas. Is that correct? Similar?
More or less. That's discussion for us, but more or less.
Awesome. And so the interesting part was, I shared that with a couple of people pretty close to me in that group I was with at the time. And the senior person in that group said, there's no way. And I was like, if they have the post x-rays to show it, then who are we to say that's not happening? When we use that same criteria to prove that ours is working. It's just, once again, the generation shift. So that was just the start of the data information. But it's interesting to think about, because one of the things that we really want to do is we want to put chiropractic on the map as being the experts in understanding the spine. We should already be. And frankly, in Dubai, the neurosurgeon stuff over there, they were really intrigued. They were like, we love working with chiropractors because you guys really know your biomechanics. But if we can have, Dr. Kent told me when I showed him all this, the beginnings of this data accumulation, he said to me, you guys have something very different than most people. He said, most people will do a study on a limited set of data, and they will take it to exhaustion. I go, what's that mean? He said, they'll try to do as many different looks at the same exact small piece of data, and as many write-ups as they can on a small piece of data. He goes, you have a ton of data. He goes, you literally will have limitless research papers that come out of what you're doing. And I was like, that's the plan. When you simply write up headaches and studies about chiropractic helping headaches, which was in that little box they shoved us in, we still barely exist. In the research world, in the box we got shoved into, remember, neck pain, headaches, and low back pain, even in that box, we have such few studies on something we're supposed to own, apparently. This is going to allow us to go into all kinds of journals. It's called medical quantification programs is what we're going to be looking to get involved with. So this next group is going to be about orthogonal effects on physical exam findings. So orthogonal is obviously inside that measuring system. You'll notice that our board changed the name of our technique from advanced orthogonal, and we rebranded it into EPIC. One of the main reasons, orthogonal is not our goal. It hasn't been our goal for a while. It was actually a misleading term. We want to put people into their genetically normal position. However, orthogonal is still a measuring system that we can use to get our degree calculations and still look at biomechanics. So we started looking at the lysis effects. We started looking at the, I need to take this slide out. We started looking at Fukuda's step test. I don't know if you remember Dr. Lamantia's discussion talking about coordination. One of the things we'll do is we'll have them close their eyes and we'll have them march in place. Well, when we do that, almost 100% of our clinics, remember the blue is the total clinics, and this is my personal in case you were just curious about comparing, because I like, each doctor's going to be able to compare their own data to the field. That's the beauty of Sonus Blueprint. You can see how you're comparing to the rest of the field. Almost 100% of the time when people close their eyes and march, they go forward. Well, maybe that's because of all the anterior head translation and the lost curves, and so their weight is forward, and nobody wants to fall backwards. They'd rather fall forward and catch themselves. But most people march and they go forward. See, about 40% of the time they rotate to their right. A little bit more, about the same prevalence, they turn to their left. You see the prevalence of translating to the right and translating to the left. It's a little more common that they translate to the left than to the right. Supine leg length deficiencies. About 58% of the time, the right leg is deficient. Otherwise, it's the left. But it's interesting, once again, my personal data compared to the field's data. That's what gets so intriguing. Because you're like, do I have a bunch of weirdo patients, or are they kind of all like the rest of them? And so you saw my older population. Well, you're seeing similarities and trends. What percentage of the time is the leg length deficiency between even and 1/4 of an inch? The most common is that a leg length deficiency will be between 3/8 of an inch to 1/2 of an inch. Now look at this little piece of data right here. Overall, there's doctors in the field that see people with way more 1-inch plus leg length deficiencies than I do.
More hills.
Yes! People are walking on more hills. Not in Florida.
I'm in Lakeland.
That was great! Man, that was funny. All right, so in the terminology that we're going to have to use to understand this comparable, when you look at orthogonal references, in Grosdick-based work, the acute upper angle, we call it the frontal atlas cranium line, FAC. That's the upper angle. That indicates atlas laterality. The FAS is the frontal atlas to spine angle, also called the lower angle. Our frontal axis rotation is looking at the C2 spinous, has rotationally misaligned left or right according to the measuring system. And on the horizontal X-ray, which is called the vertex in the Grosdick work, the atlas rotation on the horizontal X-ray is called horizontal atlas to cranium angle, HAC. We simplified the terms. Some of you guys have been away from this movement for a while. Welcome back. We cleaned up the terms. We made it way simpler than a lot of confusion. So it starts with the name of the film, moves on to the name of the structure, and then it's a line or a comparison, and so you can see the terms. So I kept those up there as we go through and talk about how does orthogonal type of measuring, how do those patterns or those demonstrations affect physical findings? Or maybe they don't. Maybe there isn't a statistical correlation. So let's break them down individually. So 83% of the time, doctors found the right C2 dorsal root ganglia to be more inflamed than the left, regardless of the upper angle. That was very interesting. When I do the talk this afternoon, you'll learn why. That was something we never knew before.
Is the doctor left-handed or right-handed?
Didn't matter. That wasn't even the issue, though. When you see the physiology this afternoon, you're going to see why that occurs the way it did. I asked Joe D'Onofrio that, why does the right DRG seem to inflame more commonly than the left? He said, I can't answer that. He could answer why when we turn the head into it, it creates the changes it does, but he couldn't answer why more commonly. And when we were doing the preparations for the symposium, you're going to see something really interesting this afternoon. Something we've never had the answer for, frankly. All right, how about atlas? When the atlas has gone to the left or to the right, and the lower neck deviates to the left or the right, if they're both on the same side, remember that's called an ipsi. If they're on opposite sides, that's called a contra. And does the side of laterality, with it being a contra or ipsi, how does that affect exam findings? Is there any correlation? The only correlation that really stood out, once again, regardless of it being a left or a right upper angle, and regardless of it being a contra or an ipsi, so this would be considered an ipsi, this would be considered a contra pattern, the right DRG compared to left DRG was always more inflamed. When you look at which leg was short, the only correlation at all was that a left contralateral pattern seemed to be demonstrating the highest occurrence in either an arm being weak or a leg being short, whether it was the left or right leg. So that means basically that's showing that there's a slight increase in prevalence if you have a left contralateral pattern, that it's going to manifest neurologic outcomes. I don't know why. It's just there. C2 rotation didn't seem to show any correlation with affecting findings differently based upon whether the C2 was left or right. It literally just was neutral across the board, almost a 50-50 split on all the categories. Doesn't mean it doesn't need to be improved. It just didn't show a direct correlation to being the causative factor of a neurologic presentation in our exam finding. But atlas rotation did. Atlas rotation was quite interesting. Because even though we looked and said, how many times is the atlas, when it went to the side, how many times did it go anterior versus posterior? It was almost a 50-50 split. But the positive theta y, for those of you who like the biomechanical thing, the positive theta y, where you're screwing a light bulb into the ceiling, which is a right anterior, left posterior atlas. That was the one that occurred most prevalent causing these indicators. So even though the prevalence of the atlas laterality was practically identical, the right anterior, left posterior atlas was occurring 66% of the time. That doesn't mean we should say, well, I don't know what their listing is, so let me just try a left posterior thrust or a right anterior thrust. But it's just interesting. How you guys doing so far? Good? All right, prevalence of biomechanical case types. So, contralateral pattern versus ipsilateral pattern, we already discussed what it would look like. And then there's a category called mixed patterns, which is they're not really a contra-ipsi based upon how the numbers work out. Inside each category, and the reason I'm going into this, I'm going to show you how we now start to move into the next level of interpreting these facts. Because inside the contra versus ipsi, we have a designation according to typical or atypical factors. Most of you know that. For example, if there's an acute lower angle, the C2 spinous typically will move into the open C1, C2 area. Typically. But sometimes it doesn't. If it doesn't, that would be a contralateral pattern with a C2 that's atypical, and that would be a contralateral pattern where the C2 FAX was atypical, so a C3 pattern is what I just described. So it categorizes the type of pattern, and it categorizes which is atypical, whether it was a single atypical factor or whether it's multiple atypical factors. So there's 8 categorizations per contra, mixed pattern, or ipsis. 45% of patterns are contralateral patterns, 32% were ipsis, and 23% were the mixed, where it's not really a contra or an ipsi. Now, if those of you haven't trained in Epic, we don't adjust people based upon contras or ipsis or general patterns. We adjust people, well, number one, because they're subluxated, but number two, going down to individual components and trying to refine the reduction of each individual component to all occur at the same exact time. But I had to explain that to you because when we start to move into the next factors, you're going to start to see some of those category things showing up. I want you to understand what that is. All right, Dr. Bulow, probably what you've been waiting for.
Okay.
Dr. Bulow, probably for you. Osseous asymmetries and their effect on the orthogonal analysis. So when you hear that I'll send it over here. When you hear that orthogonal is the goal, I'm going to say, well, you have a very interesting goal. Because I thought neurologic clearance was the goal. Being neurologically clear for orthogonal be the goal for all of us would mean we're all anatomically identical. So osseous asymmetries have been occurring, and just a lot of them just being noticed but not really evaluated. And I would hear that commonly from my orthogonal buddies. They'd be like, yeah, we see asymmetries. I'm like, well, then how does that affect your interpretation of the misalignments, and how does that change your approach and how you're adjusting them? What do you mean? I'm just adjusting them. Okay, you're seeing them, so what are you doing about it? Well, they're there. Okay, so some things that are just osseous asymmetries, some things are general things. I'm starting off real gentle on this one. One of them is just, okay, well, how often is the plane of the atlas at these degree markers? What degree is it at? So most commonly, the atlas sagittal plane reference is between 11 to 15 degrees. And you can see just the prevalence of how often this is happening. In regards to the facial features that the line comes through, so once we draw that line, it shows us the degree to set the tube at, and then it shows us the facial feature to shoot through. So, most commonly, the atlas came out through the nasium, through the S2 feature. Now you know why Grostic took a nasium film, calling it the nasium. Now, is it always going through the nasium? No. It can go below it at the hard palate. It can go above it. But most commonly, it goes through the nasal cavity. That's why he chose the nasium to shoot through. Some of you guys are just starting to develop a bad habit in Epic, where you're just automatically taking an S2 at 10 X-ray for your frontal film. Bad move. It'll work out for you 42% of the time, which means around 60% of the time, you're getting the wrong perspective of the atlas on an X-ray. Now, obviously, we're all going to shift where the angle won't matter anymore once we're on cone beam. But right now, it still matters for us all. So don't just generalize the angle you're taking an X-ray at. So approximately 60% of frontal X-rays taken through the bridge of the nose with a 13-degree tube tilt will capture the C1 surface on its plane within a 7-degree tolerance. Just an interesting point. Yes, sir.
What was the difference between the average and yours on that first slide there?
Apparently, I have quite a few people that come in and they have low atlases. That can occur in reverse curves too, where the atlas is kind of dropping like this. So that was the biggest disparity. Otherwise, the rest of it kind of followed similar trends.
No.
So axes, we take a separate X-ray in Epic to measure the C2 surface. It comes off 90 degrees to George's line, so George's line here, 90 degrees to that at the base of the dens. And you can see how commonly, once again, all the trends are following each other, whether it's my stats or the field stats. That's quite interesting. And then the facial feature, well, when people say, oh, I just take an open mouth X-ray, I'll say, hey, guess what? 70+% of the time, it should be taken as an open mouth X-ray. But what angle should it be taken at? Oh, I just set it at 0 and go right through the mouth. Okay. Well, then at 0, it'll work for you about 17% of the time. You'll get the correct perspective of C2, going 90 degrees to George's line, which means over 80% of the time, it's going to give you kind of an off reading of the C2 surface. So don't generalize, guys. That's the whole point. We're here to customize. We customize our X-ray positioning, our X-ray tube tilt, aiming, all of that based upon the structure itself. So 63% of AP open mouths taken through the open mouth with a -2 tube tilt will capture the C2 surface on its correct plane within a 7-degree tolerance. Why do we talk about 7-degree tolerance? Is because Dr. Sweat and Dr. Nygaard did a little kind of an independent study almost where they looked at the C2 surface from different perspectives. And when you moved about to the 7-degree mark and beyond of error of viewpoint, then it would change your measurement of the axial circle. All right. Condylar circles. Many of you in this room have trained with Dr. Sweat before, and you will hear Dr. Sweat say, condylar circles are usually a 3, axial circles are usually a 5. We were able to confirm that 60% of the time, the condylar circle was between a 3 and 4, and a 5 to 6 was about 28% of the time. Did you see the variation? A lot of variation in the axial circles, not nearly as much variation in the condylar circles. All right, so remember an orthogonal care, line through the skull, line through the neck, atlas line level. Okay, that's our orthogonal line drawing. The problem is, if condyles are not level, but if condyles are tilted, then the atlas should be tilted to match it. Have any of you ever adjusted somebody knowing you were going to make them less orthogonal, but because you took the epic analysis and realized the condylar tilt that was occurring, and you having to make the atlas match the condyles, you adjusted them and they became less orthogonal on a traditional analysis, but once you factored in the aberrancy assessment we show you how to do, you realized they were neurologically reduced. And the patients did fine. That has to be understood. Because we found that 38% of the time there is a tilt in the condyles compared to the plane reference of the skull. So 38% of the time, the condyles are not 90 degrees to the rest of the skull. 38% of the time. 80% of the time, that tilt is on the side of atlas laterality. So, and I am very bluntly making these references to some things that Dr. Sweat has said because he's my mentor. And I remember him saying, well, if you're ever confused about the upper angle, always adjust on the side of the higher condyle. That's kind of a drop back. And 80% of the time, that would have worked out. 17% of the time, once you threw in the articular consideration of how the condyles are tilting and how the atlas needs to match that into an orthogonal analysis, 17% of the time, you'll realize the atlas is actually lateral to the side opposite of the upper angle. It switched the side of laterality once you considered the articular model inside the orthogonal world.
That's not very many unless it's sheared.
Yeah. Well, 17% means basically one out of every 5 patients. That was pretty interesting. No, it's not actually 1 out of every 5. Excuse me. 38% of people have it. So 3 out of every 10 have aberrant condyles. Out of those 3 17% would have shifted it to the other side. So it's not 1 out of every 5 patients has been adjusted on the wrong side. That's not what I'm saying.
No.
It's 70% of people with aberrant condyles, the interpretive value will cause you to have to move to the other side for the adjustment.
You had a question or comment? I was just going to say, I was looking for that on reading those stats. I haven't run all the stats, but it's about accurate. So, I was looking for it for the presentation. I found a couple of them. One was short condyle. Most of them it was lateral on the side of the short. It just changed what the resultant acuity would be. And then one where it's the opposite, but I had to dig for that opposite one.
Yeah. Well, out of 2,000 plus cases, now you start to see the trends have shown up pretty clear.
Yeah, that's great.
All right, elevated atlas plane line. So you know how we talk about the atlas moves out and around up the condyles? Well, we talk about this always adjusting on the side of the high plane line, high atlas, as though the skull is fixated and upright, like locked upright, held by a string, and so atlas must go up and around the condyles. We were able to measure that 70% of the time, the atlas plane line is above level on the side of laterality. 70% of the time, which means 30% of the time it's actually lower. Asymmetrical atlas. If we zoom in on the frontal and you see the atlas bone itself, you have the superior tips of the atlas, the inferior tips of the atlas, the inferior arch insertion, and the superior arch insertion. We were able to look at how often are those features aberrant. Abnormal. Yeah, 20% of the time the superior mass is aberrant, inferior mass 26% of the time, and the inferior and superior arch 18% of the time they're aberrant. We talk about that in EPIC. How do you take those aberrancies and determine a consistent line of reference through the bone structure when those aberrancies exist? We teach you guys how to do that in the fundamentals and the basics, as you know. Boot camp. On the horizontal film, the atlas with its transverse foramen, 90 degrees to the anterior posterior tubercle, we call it the neural canal. We have reference lines going through the transverse foramen on the front and back side of the superior mass kidney bean at 90 degrees to the arches, called neural canal. We were able to see that 7% of the time this anterior mass is aberrant, 3% of the time posterior mass was aberrant. Transverse foramen was aberrant 11% of the time. Interesting thing about that is transverse foramen was the Grostic standard. Like that's what you dropped your line through. We found it was one of the more aberrant features on the atlas. Doesn't mean you would never use it. I'm not saying that. In cases where it's consistent with the rest of the atlas, we'd still recommend you use it, but had a lot of asymmetry. And then getting into the quality control assessment for the standard of care inside EPIC. Once you enter in your data, the software itself will give you clinical guidance on how to do the setup. So for example, right up here, you'll see where it shows you how to set the headpiece height, headpiece angle, how to set the shoulders, which direction to set them, and with what multiplier to set it. So do I set it a little posterior or very posterior? Do I set it a little high or very high? It tells you the biomechanical influence to utilize on that case. It also has the instrument calibrating right here. So it shows you right here the height setting and the X-rotational setting. And this modifies based upon the head height angle. For those of you who know, once the patient's on their side, if they're not laying level, they're laying elevated, then if we're accurately adjusting them, then we have to take into consideration their body plane. Otherwise, our SI line of drive is going to be errored by whatever postural non-level the patient's laying at. And then we have aiming assistance, locating the TP, what your lead needs to be. I will tell you ahead of time, we're starting to work on depth of tissue. Is it a thick patient or a thin patient? Mm-hmm. Once we go to cone beam and we can actually measure that thickness, you'll be able to see how far of a lead you need to get to the TP and based upon the actual tissue there. And we've got an instrument capable of actually measuring and doing that. Our adjusting device actually has the ability to hone in with laser guidance on that. And then we have a rating system inside here, which is an orthogonal rating system, which means from orthogonal, how many degrees are they off? And the other rating system is how far are they off that's outside the considerable normal range of motion based upon Grostic and Punjabi's work.
Before you go too far past that one, did anyone in here who doesn't practice EPIC realize how geeky we are?
Oh my God.
That's one I just looked up and went, oh my God, we look so geeky.
I was saying that Blair, I thought we were the geeks. You guys are like savants with this stuff. So that's
Thank you, Dr. Day. It's beautiful.
Well, the whole point of this is to make it user-friendly.
Yeah.
You have to have students that don't have to know every detail of all this stuff, able to still fix people, while they're still learning to master the why. This allows them to incorporate the steps to fix people well. because we need students graduating day one rendering just as good care as a 40-year vet. This is our attempt to make it dummy-proof. It's huge, but you still have to know the why behind what you're doing. So what about breakthroughs? I mentioned to you the other day that breakthroughs are occurring in every technique in different clinics around the world. But how do any of us know? Gary, if your practice, you're having a breakthrough, how would I know that you're killing adjustments better than I am? That in certain case types, you're just the man. What are you going to tell me? Yeah, of course, everyone's the man. Well, what if we were able to see it? What if statistically we could see the breakthroughs happening before the doctor even knew it was happening? What if the doctor saw he had breakthroughs? He's like, whoa, I'm actually doing pretty good in this. Hey, Dr. Stan, look how I'm doing with these case types. Because what it does is this data system will track out and show you this 0 mark here, right there, is showing you if you didn't change much orthogonally, cumulatively, versus how much were you able to control reductions in each of the case types. So first we can look at the orthogonal reductions here. Oh, and actually, by the way, when I first showed you the case types, I'm sorry, I'm glad we're practicing this because I forgot to mention to you, when I was showing you the C1 through 8, M1 through 8, I1 through 8 case types, that was also a prevalency trend of how commonly those case types are occurring around the world. Like you can actually see the frequency of which case types are showing up more often versus less often. But what this is showing is how well are we reducing the misalignments with our adjustment. So if you're a doctor and you're noticing the field, the total orthogonal reductions, the field is generating these kind of reductions. You can see the field is, generally speaking, reducing orthogonal misalignments about 40% with their adjustments. In these case types, they struggle a little bit more. In IPSEs, it's a little bit varied on a certain case type. You can start to see where the field struggles, but what if your stats are staying right on the best line of being able to say, hey, I'm doing pretty good compared to the field. But then this next chart actually shows the breakdown of each case type and how you are comparing with the average in the rest of the field. So this doctor, compared to the rest of Epic clinics, is getting about 20% better reductions in this case type. So you look here and you say, oh, this doctor could be pretty happy. He's doing better than the average standard of care in Epic. In these cases, this one and this one, wow, he's way out producing the other docs. So we need to go to that doc and be like, hey, what are you doing in these two case types? You're seeing it better than we're seeing it. We got to learn from you. But that doctor could also see, ooh, in this case type, I need some work. Yes, sir.
I have a question. In this data, is it incorporated on the age of the patient, or maybe it just takes more time to get the reductions that you're looking for? Because there's a whole physiological component. Where like if you were to post in 6 months, you might see those cases just dramatically improve when you recheck all your numbers.
It could. So let me tell you this though. This happens to be my stats, and I work with oldies.
Got it.
So if the age was the issue, and the people's stiffness in their bone structure wasn't responding, then you would see my work.
I'm not saying elderly, it could be any age.
It could be. So here's the cool part. With Sonus, we can cross-reference that data easy.
Well,
We can say, and we will, there is endless data point cross-referencing through this. So we can see which case types with anterolaesthesis at age 12 through 20, how do they respond versus... If you were looking at this and you'd say, well, this shows me how I'm doing in the overall case type, but okay, if I'm struggling in a certain case type, why would that be? So then the doctors can take whatever they want and move it into the next, meaning go to the next graph, and it'll show them different case types and different reductions and areas that they need to work on. So in each case type, you can see each biomechanical influence and how they're reducing it compared to the rest of the field, and they can see where their areas of weakness are to work on, or areas that they're killing it and other people can learn from them. Get the idea? Yes, sir.
just one more thought. What about 6 months out? I'd love to know what happens 6 months out, you know what I mean? Or,
I'd have to take new x-rays and see.
yeah, it'd be so cool. Because maybe you see the tough cases just completely clearing.
Maybe so.
Yeah.
And then ultimately we say,
That's right.
if we can standardize clinical outcomes, then we can compare results from one technique to another to find out what approaches are more effective for different case types. Just like you heard Dr. Bueller saying earlier. Our technical goals is to have a standard of care that can be measured, questioned, modified, and remeasured. It's constantly got to be in that process. Most people struggle to measure it. Very few people are willing to question it. Modify it? Why would you change what's always worked? You hear these phrases all the time. And then remeasure to see if your modification was actually right. What if I were to tell you that right now we have a standard in Epic where you're supposed to influence things this way, headpiece height? What if it's wrong? What if things that we've been taught over the years are not as effective as they should be? We're starting to do that in Epic, where we're actually looking at the statistical reductions in these different case types and seeing if the field has a trend where things aren't reducing as well because we're applying things we were told, rather than what the research is showing us we need to do. And we've already started making modifications in the technique based upon the research outcomes. Then we have to duplicate it. So we have to have an academic ability to duplicate this in the classroom. Many of you guys have already taken Epic in the classroom. Clinical duplication, critically important. That's why we have Sonus Blueprint to guide you. And then you got to have the right technology to be able to render these adjustments on the correct axes and gentle and controlled mechanisms. Results, we have to see improved clinical indicators. Why does this matter? If patients aren't getting better, why does it matter? So we actually have more tracking than what I've already given you. I'll go over some of it this afternoon. And then how well does it hold? What kind of longevity are we seeing in patients? So the patient outcomes, that's what's going to determine the marketplace, and then how we position inside that marketplace. Ultimately, our primary focus in Epic is to use mathematical observations to establish a standard of care that doctors can hold themselves accountable to. We're then going to equip new doctors with understanding, training, and technology to generate measurable, high-quality patient outcomes on their first day in practice. We want to then develop a scientific platform that can evaluate the efficiency or efficacy of Epic in reducing subluxations. So how are we doing our job right? We need to know that. And then we're going to discover conceptual or technological breakthroughs occurring in practices around the country, learning from each other basically, because we're going to develop a chiropractic community that's constantly learning and growing together while improving patient outcomes. Because once again, chiropractic is a science just so far as it is specific. How was that? All right, so give me feedback on the break. We're not going to break yet. We're going to our last segment of this morning, which I'm really looking forward to this. Do you already have your computer? Are you using your computer, Doc? Are you just talking from the... You're next. Yes, sir. You're coming up next.
5 minutes.
Okay, so we're going to take a quick 5-minute break and get right back in your seats. We've got Dr. Robert Brooks, who's going to be lighting us up.